Good afternoon. Welcome to Wonderful Wednesday, to part 2 of Open That Chest, Cardiac Trauma, Surgical Emergencies. And today we're going to talk about acute aortic dissection. Aortic dissection that may occur because of your patient being hypertensive, or a traumatic aortic dissection that might occur with most particularly with a blunt traumatic injury. So really important when we're thinking about those patients. And just to remind you about your aorta, and this is a very bizarre looking aorta, of course. Here comes the aortic arch, and here is the ascending aorta. And often what we can see is a tear in that inner lining of the aorta, and blood will move into that tear, creating a lot of pressure, and then, of course, the possibility of dissection. So when we talk about cardiac trauma and we talk about aortic dissection, really important to think categorically about patients who actually have cardiac trauma and aortic dissection. First and foremost, aortic transection that can occur for any traumatic type of injury, including blunt cardiac trauma or penetrating cardiac trauma, and also for patients who have already had emergency resuscitative thoracotomy. So that could be in the post-open heart patient where you open the chest and you're doing some level of resuscitation. You can actually see significant cardiac trauma and aortic dissection. If we are evaluating the patient, if we have time, and we are evaluating patients, it's always important to remember that what we expect to see on chest X-ray, which will not be may not always be sensitive depending on where the patient is in their dissection process. But typically what you're seeing here is free blood and a widened mediastinum. And here you are also seeing how it's pushing the trachea over. So we indeed, in this patient, have tracheal deviation. In this patient, we do not. And that's really important because a lot of times we're evaluating patients, we're looking for the placement of the trachea. Tracheal deviation may not occur in every patient. And so we are very grateful when we have that as a positive sign, but we're not anticipating that we're always going to have it, and we're not relying on that perspective. Typically, if you don't see a widening of at least 6 to 8 centimeters, you may not be able to see it on X-ray. And here in both of these patients, you can see when you're looking at the X-ray, you don't expect to see this really large knob. This is not the aortic knob. This is the bolus of blood that is persistent in the intimal tear of the aorta. So really important to remember, of course, that aortic dissection is always a very serious condition when you have a tear in the wall of the aorta. And blood is surging into that tear. So I want to make sure you hear that. Blood is surging into that tear and into the separation of the intima, the internal, and the middle lining, and creating what we call a false lumen or channel. So for a period of time, what's going to happen is that area is going to engorge until it can no longer distend. And that, of course, is when it's going to dissect and rupture. So it is really this false lumen or channel that's occurring because of the tear in the intimal lining. So, of course, that means blood is gone where it doesn't usually go. And that's what causes that separation. That's, of course, what we call the dissection. But if that dissection persists, and if it's accumulative rapidly over time, what's going to happen is the blood is going to burst through that outer wall of the aorta. And now the patient is internally bleeding. He now has a hemothorax. He's going to bleed to death, and he's going to die fast. Okay. So for me, what's really important is if you're really, really, really lucky, this process may occur over an hour or a few hours, giving you time to evaluate it, to prepare to treat the patient, to medically manage them. But if when you see your patient, the blood has burst through the outer wall of the aorta, your patient now has an open internal wound where they are bleeding freely, and they will die in the space of minutes. Now, really important to remember in a blunt cardiac injury, so most particularly looking at motor vehicle collision, depending on where you are in your cycle, which we can't do anything about. Are you in systole? Are you in diastole? Are you really full? Are you partially empty? When you hit against the steering wheel, the weight of the heart is actually going to participate in some aspect of the tearing. So if you are at optimal filling and you've not yet ejected, the weight of the heart is going to be much greater, and that's going to put much more shear force injury on the aorta and on the intimal wall. And now every time the heart contracts, blood is going to go into that tear, separating the intima from the media and eventually causing a rupture of the outer aortic wall, and you're going to bleed into your chest cavity. Okay, so really, really important to appreciate. If I have time and I really want to pay attention to these criteria, I have a patient who has sudden onset, acute, severe, profound chest pain, or they have pain that begins at the front and goes to the back. So front to back or back pain. So acute severe chest pain, front to back, or an acute severe back pain. Very first thing that I'm going to look at is, do they have equal pulses in their upper extremities? I might also look at whether the blood pressure is equal in the upper extremities, but I may not have time. So I'm just going to quickly, as the bedside nurse, try to feel the pulse in both extremities, and I'm going to expect to see that there's a pulse deficit if my patient is actually dissecting. If I have time to get a chest x-ray, I'm going to see this mediastinal widening on the chest radiograph, and I may or may not see a tracheal deviation. Really just depends. Depends on the size and the degree of the aortic involvement, the amount of dissection that has occurred, and the space occupation of that free blood. But once you have dissection, you have minutes to act, and sometimes not even that. Once dissection occurs, you have minutes to act. So we're going to talk about what those minutes are and what that means to us and what it is we want to do. 75% of patients who have a ruptured aortic aneurysm or a blunt aortic dissection, 75% of those patients will reach the emergency department live. But with a full dissection, 40% of them will die within a minute of the occurrence. Not time to get an EMS, not time to get in a helicopter, not time to get to the hospital. They're going to die. Out of those patients, the 60% who survive, 50 to 70% of them will be alive 5 years after surgery, depending on their overall condition, the underlying cause of the dissection. Is their hypertension under control? Are they elderly? Do they have congenital deficits that actually lent towards this dissection? All of those factors are going to actually impact their survival rate. The single most important thing is prompt diagnosis and effective therapy that is actually going to help you to survive. And what I'm going to remind you of is, if you have significantly dissected, you are probably not going to survive to get to any clinical attention, not to EMS, not to the emergency department, not to the OR. If they happen typically in a patient who is already in the hospital, they tend to be less acute and less likely to progress rapidly to mortality. So very important to kind of recognize the difference between these two types of occurrences. One that might be occurring under your care because your patient has had multiple hypertensive episodes where they have actually supported a tear in the lining, and the other where they've had a blunt cardiac injury. For untreated acute dissection of the ascending aorta, so from leaving the aortic valve and ascending upwards, mortality is 1 to 2% per hour after the onset, which means you have to recognize it's got to be diagnosed, and you need to open the chest. Chest needs to be open. Now, I'm not necessarily advocating that you're going to open a chest in the ED. You really want to get the patient to the operating room if at all possible. We do open chests occasionally in the ICU if we think it's necessary. But remember now, we're not talking about a patient who has had previous chest opening. So in other words, for the person who has had open heart surgery, we're going to cut their wires. We're going to use a retractor, but they've already been opened. Their bone has already been sawed. It's much easier to open the chest. We get inside, do internal massage, internal defibrillation. That's a patient whose chest was already open. That's the CTS patient. Now we're talking about somebody who comes in through the ED who we think has had an acute aortic rupture or dissection from a blunt motor vehicle injury or from uncontrolled hypertension. Their chest has not been open before. We're going to think about, how do we open that chest? How do we do that safely? How do we do that as sterilely as possible? And how do we ensure that the patient survives until a cardiothoracic surgeon can be brought to see the patient either in the ED or in the hospital? It is really important to remember that with these types of dissections, even if there's rapid surgical intervention, and actually typically medical intervention and surgical intervention, because medicine I can do immediately, and opening the chest is going to take a minute or two, shouldn't take more than 3 minutes actually, but it's going to take a couple minutes to open up that chest and get inside and deal with what's going on, try to repair what's happened. The medical therapy component is also going to be really, really important. Now you can hear, and what I've said to you is that the more forcefully your ventricle is ejecting, especially against a constricted aorta, the higher the blood pressure is. The higher the blood pressure, the more you're going to dissect. So we always would like to bring your blood pressure down, but before, and we'll have this multiple times in this talk, before we do anything to bring your blood pressure down, we must control your heart rate. So heart rate down first, blood pressure down second. Now I'm going to do that really quickly. I need to have emergency medications available very quickly. I'm going to use either a beta blocker or a calcium channel antagonist to get your heart rate down, and I want your heart rate less than 60. And then I'm going to bring your blood pressure down. I want your systolic pressure. Typically, I would like to see it less than 100. So I'm going to bring the heart rate down first. I'm going to bring the blood pressure down second. My doc should be asking for that. And if they're not, I'm going to ask them if that's what they want. Because what I'm going to try to do is limit the amount of dissection that has occurred by controlling your heart rate and by controlling your blood pressure until we can get your chest open. Okay, so always really important to remember that my goal is to limit your tear and your dissection, to limit the amount of hemorrhage that's occurring, to limit the amount of blood that is pocketed in the aorta. And this is going to be the best way that I can do it. First medical and then surgical. Okay, so 70% of patients who have an intimal tear in the beginning, that 70% occurs in the ascending aorta. Okay, this is an emergency. It's a surgical emergency. In 20% of patients, it occurs in the descending thoracic aorta, and that's not nearly the emergency that the ascending aorta is. So again, position of the dissection, ascending, descending, thoracic, or abdominal, is really, really important in terms of the urgency that we're going to feel and what we're going to do. Now, we qualify these by using a terminology. One is named for Dr. DeBakey, the other is named for Stanford Medical Center. So Dr. DeBakey said there's really basically 3 types of dissection. Ascending that has progressed to descending, so both ascending aorta and descending aorta, ascending only, or descending only. And remember, anything that's involving the ascending aorta is always going to be surgically emergent. Okay. Now, if it's only in the ascending aorta, which means it hasn't gone down that descending shaft, the pocket of blood that is accumulating here is going to be much bigger and is much more at risk for rupture. Whereas here, it's distributed over this longer intimal tear and longer surface area that's involved. The only reason I want you to understand this or remember this is type 1 and type 2 DeBakey is ascending, okay? Type A Stanford is ascending. And if type B is involved in here or type 3 is involved in here, that means that we've got some other subtypes. Subtypes, it's either thoracic or diaphragmatic. And what you need to remember, type 1, ascending, is a surgical emergency. That's what we have to consider. Now, we got to think about patients who are at risk, okay? So, of course, anybody who has uncontrolled hypertension, And that's present in 70 to 90% of patients who have an acute dissection. Uncontrolled hypertension. So depending on where you work. So I work here at Grady. I unfortunately, or not me unfortunately, but my patients unfortunately do not always have access to primary care, may be uncomfortable with their medication, don't go back to their doctor, don't have a doctor to discuss it with, so they just stop taking their medication, made them impotent, they feel really lousy, they can't get out of bed and go to work, they're so exhausted with their medicine, they stop taking it because they don't really feel the side effects of hypertension until it's really late. So again, hypertension, most particularly uncontrolled, is going to be the biggest villain in acute dissection. Older age, typically between the 6th and 7th decade of life. So between 60 and 80, 60s and 70s up to 80, this is going to be a pretty significant time period that you're going to see patients who have aortic dissection. Now, doesn't mean that 80-year-olds don't have dissection. It's just that the pool gets smaller at 80. So people live to their 60s and 70s. They may have controlled hypertension, or they have uncontrolled hypertension. They may have controlled diabetes or uncontrolled diabetes, all of which is going to put them more at risk. They're 70 with hypertension uncontrolled, diabetes uncontrolled. They're going to have friable intimal walls. They're going to be much more likely to actually have aortic dissection. It affects men two to five times more than it affects women. I shouldn't say male sex. I should have said male gender. Sorry. It's not having male sex that puts you at risk. It's being a man puts you at 2 to 5 times more risk than being a woman. Marfan's or other congenital or inflammatory disorders also put those patients at risk. There's a list of around 20 that are actually developmentally prone towards aortic dissection. So just being aware that when you hear somebody come in and they say, oh, I've got Marfan's, or I've got other kind of inflammatory or collagenous disease states that are congenital or inflammatory states, always be aware that that puts them at more risk for aortic dissection. Pregnancy, because of the increase in circulating volume, and pregnancy plus hypertension or pregnancy plus preeclampsia puts women, even young women, at risk for aortic dissection. And then, of course, trauma. So trauma is a deceleration injury, meaning your chest hits something really hard and you stop forward movement. And again, depending on the weight of the ventricle and where you are in your cycle, the ventricle will swing back and forth inside the chest. That will put tremendous force on the aorta and promote an intimal tear. So whenever we look at torsion injury, twisted injury, so I had a high speed impact, my body twisted and was forced up against the steering wheel or forced up against the front column. Those are injuries that are going to put me at risk for aortic dissection. So immediately when you get those kind of patients, in particular, anybody with a seatbelt injury, you are immediately going to think about the possibility of aortic dissection. And of course, they get ruled in or out pretty quickly because they're going to get a wide variety of imaging. It might be that they first get a chest x-ray, they get a cardiac MRI, they get a CTA. They're going to get a variety of tests to evaluate the possibility of aortic dissection. The most common symptom for patients is chest pain. And it is severe, ripping, not pressure, ripping, burning, typically front to back chest pain, acute onset, no warning, not like acute coronary syndrome, having a little pressure, oh, it got a little worse, now I've got a lot of pressure, an elephant is on my chest, I can barely breathe. That kind of progressive perspective. Not everybody with acute coronary syndrome has a progressive chest discomfort, but this type of chest discomfort, that patient is prodromal. They're like, I'm going to die, because they've got a lot of sympathetic discharge and they're telling you they're going to die. They're agitated, they're twisting, they're turning, they're trying to find relief. This is just so severe. So it is easy to think that this is acute coronary syndrome, to actually go down that trajectory, and that's okay. It's okay, but it is really important that rest does not improve things for this patient. And you must be very careful about giving this patient nitroglycerin, because you never want to vasodilate somebody who's having a dissection if you are not controlling the heart rate. Okay, now that's really important. If I think it's a possibility, even though it sounds like it might be acute coronary syndrome, I think it's a possibility that it's an aortic dissection. You're not going to get nitroprusside, you're not going to get nitroglycerin, you're not going to get nicardipine until we've evaluated you. Because I do not want to vasodilate you, which will cause your heart rate to go up. And then that projection, that rapid projection of blood into the aorta will make your dissection worse. So we got to control heart rate first and bring your blood pressure down second. Giving you any drug that is going to promote vasodilation, you must do that in conjunction with cardiac rate control. Otherwise, you're going to proliferate and actually significantly contribute to the dissection. Okay, patients with type B dissection, that tends to be more thoracic or down into the abdomen, depending on what scale you're using. So either thoracic aneurysm or abdominal aneurysm, or thoracic dissection, abdominal dissection. I'm sorry, I said aneurysm, but I meant dissection. Typically, those patients have back pain. They don't really have chest pain, because what's happening to them is below the heart. Remember, if it's an ascending aortic injury, it's right at the heart. And that's why it feels like chest pain and chest pressure. Second common cause is significant syncope. And that's a very well-recognized feature, but still it only occurs in about 13% of patients. And that's really related to the fact that they're transecting their aorta, so a significant reduction in cerebral flow is occurring. So they have an acute cerebral hypovolemia, they're bleeding into their chest. Overall, their cardiac output, actually the blood flow to the brain, is very low. They may also be dissecting up the ascending aorta, and that may communicate into the cerebral arteries, and they may also be dissecting their cerebral arteries. So very, very important. Now, patients who have presentation of syncope, they are much more likely to die than those who don't have syncope, because they have such a significant alteration in cerebral blood flow. So by the way, Bronny, so I don't know if you know anything about Bronny. Bronny is LeBron James' son. I guess he's at USC playing football or basketball. I don't know which one. I'm not very good at sports, but Bronny had a cardiac arrest. He's a young, healthy guy. He's playing basketball, and he has a cardiac arrest. Okay, so very first thing that the people coming to his bedside or to the court side to resuscitate him actually have to think about: does he have aortic dissection? Did he have traumatic injury to his chest from a ball or from someone's head? Does he have aortic dissection? Does he have long QT syndrome? Does he have electrolyte abnormalities because he's dehydrated? Right? Those are going to be the first three things in somebody who's young and healthy. Do we know if he has uncontrolled hypertension? No, we don't know. So these are really important things to remember, that, all of a sudden you're playing basketball and now you're down on the ground. Okay, so you have a cardiac arrest. Is it a cardiac arrest from a combination of problems, electrolyte imbalance because you're dehydrated? Do you have long QT syndrome? Or could it be cardiac arrest from an aortic dissection? Now we know that's not what happened to him. He didn't even stay in the ICU 24 hours, which means he did not really get TTM, which means that after resuscitation, he actually had neurologic recovery and could follow commands. Remember, we only do TTM for people who, after return to spontaneous circulation, do not have neurologic recovery, can't follow first order commands, can't give me a thumbs up, two fingers in the air on either side, can't do something that requires performance that's not brainstem. So that already told me, like, when they were doing his resuscitation, that he responded very quickly. He went to the medical surgical floor today, stayed in the ICU for less than 12 hours, went to the medical surgical floor, is probably going to go home in the next day or two, probably going to come back and have an EP study to determine, does he have long QT syndrome? And I'm going to take a bet that it is long QT syndrome. Okay, so again, remember that acute onset of severe chest pain or back pain but also really, really important. If you are having an ascending dissection, you will have asymmetric limb pulse and asymmetric blood pressure. So that's a really important aspect for us to consider. A lot of the other things, you may have aortic regurgitation because the pressure of blood in the aorta is forcing blood back into the LV. It's very hard to hear that. And unless you're really good with heart sounds, this is not the time for you to be learning. You may also have a very significant cardiac tamponade. Of course, if you've ruptured the wall of the aorta, you are now bleeding into the cardiac environment, and now you may be compressing the myocardium, and you have a very large pericardial effusion, and you may look like you have ACS. So here's the problem. The problem is that you can have an absolutely normal examination. You may not have tracheal deviation. You may have hypertension, which would give me a lot of concern, much more concern than normal to low. Normal to low blood pressure doesn't necessarily support dissection unless you are actually in hypovolemic or hemorrhagic hypovolemic shock. So blood pressure is not going to be very meaningful to me here. Okay. The biggest thing I'm looking for is asymmetrical pulses. And I need generalized labs are going to look like ACS, your troponin is going to be elevated, et cetera. What I really need is cardiac imaging. And I need that as quickly as possible. If I want to make good decisions about therapy and what's going to happen, you need to have cardiac imaging as soon as possible. So really, really important to kind of look at this, a very nice table that just says the structures or arteries that are involved here actually are what's going to give you your signs and symptoms, your clinical findings. What I think is really, really important is when we have an ascending dissection, you're going to involve a lot of cerebral arteries. That's why you have stroke or syncope and why you have neurologic changes. And then, of course, as you descend down towards the abdomen, looking at the organs that are below where that dissection is, those organs are going to be affected. So when I've got an abdominal dissection, my renal artery, my celiac artery, my common iliac arteries, those are all going to be involved, right? My subclavian, not so much. My brachiocephalic, not so much, because this is now an abdominal dissection. So everything below that dissection is going to be actually involved with very significant reduction in blood flow dynamics. Okay, so it kind of brings me to bring this together to say this is the clinical triad of a patient with aortic dissection. And I'm sorry, my friends, I wish it was a lot more specific. Okay, sudden onset of thoracic or abdominal pain with a sharp, tearing, or ripping character, unbearable, prodrome. That patient looks at you and says, I'm going to die. Please don't let me die. I'm going to die. I'm going to die. Just like they do with the massive PE. And you know what? Most of the time they're right. They're going to die. They've got that really high level of sympathetic overload. A lot of sympathetic stimulation makes them feel like I'm assuming, I don't know, but makes them feel like they just did a gram of cocaine or they took some methamphetamines. They are really, really agitated and anxious. So pay attention to that. All of a sudden, the patient who is relatively calm is profoundly agitated and anxious and is telling you they're going to die. And they're saying, something is stabbing me. This is the worst pain I've ever had. I feel like something's ripping my chest apart. Oh my God, get your docs on board, get a surgeon on their way. Talk about the fact that you've got to control the heart rate and you need to reduce the blood pressure. Do not reduce the blood pressure before you reduce the heart rate. So that's pretty simple. You're in charge of what drugs you're hanging. So just hang your beta blocker, calcium channel antagonist first, and your vasodilator second. Second thing that can happen, but it really depends on where that dissection is a variation in that pulse, the pulse to the bilateral extremities. So and it could also be in the carotid if it's an ascending aneurysm. So what we're feeling is a dysynchronous pulse. So earlier when I assessed you, you had equal pulses bilaterally, but now you have a stronger pulse on the right side than you have on the left side. And it's not just a little bit, it's usually quite profound. There's a big difference in the pulsatile quality bilaterally when we're looking at these individuals. And then last but not least, of course, is the widened mediastinum or aortic widening on chest radiograph. So very quickly, somebody who comes to the bedside is just going to do a very quick, rapid overview of differential diagnosis. Is it ACS? Is it a massive PE? Is it tension or spontaneous pneumo? Is the patient regurgitating without aortic dissection? Did they rupture their papillary muscle? Is that do they have severe mitral regurg? So we're looking at multiple events that in a minute you have to basically rule out. And sometimes it's just best to go to the worst case scenario and support the patient against the worst case scenario, because if you're not supporting the patient, they could die while you're sitting and thinking and discussing, all of which is integral and needs to be done, but not in this moment. Okay. All right, so I want to remind you, first of all, chest x-ray with the widened mediastinum. And again, this patient has a tracheal deviation. It's not significant here. You can see it on chest x-ray. It may not be that visible externally, so don't hang your hat on it. If you've got it, it becomes pretty clear you've got something that is occupying space in the chest cavity. It could be an acute hemo, could be a tension pneumo, or it could be aortic dissection with an intimal tear and a big high accumulation of blood volume. So from there, I might do a quick ultrasound to see is the patient actually in pericardial tamponade. So I'm looking for fluid in the pericardial sac and compression of the heart. But most importantly, CT angio is going to be the highest sensitivity and the highest specificity. Used to be that we did an aortogram, but now we do CT angio. So this is your CT angio. And see this right here? This is your dissecting aorta. Now you expect the aorta to be completely white, right? Because it's fluid and it's accumulating the radiology scan or the radiology rays. But here, what you're seeing is this separation inside the aorta. You expected that whole thing to be nice and white. You see that it's white, but then you have this lining that is separated. On the other side of the lining, it's also nice and white. This is a CTA of a patient who has an aortic dissection. So very first thing, if you don't already have it, got to have 2 large bore IVs. Get them quick because your patient's going to bleed and it's going to bleed to death. Got to get the biggest IV possible. If you need an IOS, do an IOS. If there's somebody there really skilled to put in a central line, but I'm afraid that's going to kind of compound some of your issues, because then you could also pop a pneumothorax and then you're even more complex. So just try for 2 large bore IVs to start with. Put the patient on the monitor, make sure you're monitoring. But remember, very first control, get that heart rate below 60. So beta block, calcium channel antagonist, maybe both together. Second, once I've got their heart rate down, so maybe they were 120 and now they're down to 70, you're going to titrate up on your beta block, you're going to titrate up on your calcium channel block, but while you're getting down from 70 to below 60, you now need to control their blood pressure. And typically you'd like to get systolic pressure below 100. Now you don't want it to be at 50, because then it's going to be hypoperfused everywhere. But you need systolic pressure to be below 120, and in some cases below 100. Systolic pressure is going to reflect the force that the LV is ejecting into the aorta. And the more forcefully you're ejecting, the more likely is you're going to have a terminal dissection. So let's not allow that to happen. That's something we're in control of. And third, even though your inclination is to do it first, step 1 and step 2, I'm saving your life. Step 3, I'm saving your life and reducing your pain. So I'm going to do step 1 and step 2, and I may even do them close to the same time, but I've got to get that blood pressure down before I vasodilate you. And then I'm going to control your pain. And I'm going to control your pain most particularly with vasodilating drugs like fentanyl, like morphine, like Dilaudid. They're all vasodilating agents. So again, you got to get that heart rate down before you do anything else. Don't control the pain until you get the heart rate down. You got to get that heart rate down first, because that's going to promote a shear force injury. Now, if this is an ascending aortic injury, this is a cardiac surgical emergency. You got to open that chest right now. Remember, if it's descending or abdominal, typically you may have some malperfusion. We may do an urgent aortic stent or take you off to the OR, but I don't have to open your chest at the bedside. If you are dissecting the ascending aorta, it's a surgical emergency, and we're going to open your chest if possible. We're going to open your chest at the bedside. So we need to be prepared for that when we're talking about the kinds of patients we see, especially if you do trauma, you need to be prepared for that. Okay, you need to call a CT surgeon, but meanwhile, you're getting prepared to open up the chest. And many ED doctors are quite comfortable with opening up the chest. You certainly see that if you ever watch any TV medical shows, but in reality, most ED docs, and especially really experienced ones, are comfortable with opening the chest. Remember, if it's descending or abdominal, I have more time. If it's descending or abdominal and you have signs of malperfusion, you're going to go to the OR pretty quickly, or we're going to stent you pretty quickly in the lab. If you are not showing signs of malperfusion, we're not going to be too worried about you. We're going to send you off to the ICU. We're going to manage you medically. We're going to monitor you. We're going to do a serial cardiac visualizations to see if it's getting worse or better while we're controlling you medically. Okay, so this is a really incredible picture of a penetrating injury to the heart, and actually is a penetrating injury to the right ventricle. This patient who has a penetrating injury to the right ventricle is going to die if we don't repair him, and we've got to repair him quickly. He is tamponading. He's got a laceration of the ventricle. He is also somebody that you're going to open. Now, remember, this is different than the CTS patient who has already been opened. Anybody who has been trained, can be a nurse, it can be an MP, be a PA, it can be an MD. Anybody who's been trained can actually cut the wires, put in the retractor, open the retractor, and open the chest if they've been trained. But if the chest has not previously been opened, only an attending physician or a CT surgeon can open that chest. So there's a big difference in how we're going to handle those patients, because with the CTS patient who needs their chest open, you're going to start opening the chest immediately. While the CT surgeon is coming, you're going to already be opening the chest. Here, you've got to have an ED doc or a trauma surgeon or a cardiac surgeon who is comfortable with opening the chest. And what they're wanting to do is an emergency resuscitative thoracotomy. So following blunt injury, if you are tamponading or penetrating injury and you have a cardiac arrest. So again, you come into the ECC, you have a penetrating injury, you have a blunt injury with a cardiac tamponade, not just a standard blunt, but a cardiac tamponade. Within 10 minutes of a PEA arrest, you're going to open that chest. And that chest is going to be opened by a left anterolateral thoracotomy, usually through the fourth intercostal space to the lateral surface of the left ventricle. Here, we're going to be able to evacuate blood that's in the pericardium. We're going to be able to apply open cardiac massage, and we're also going to be able to clamp the descending thoracic artery. Now, we do that to actually give more blood up in the aortic arch, enhance coronary artery, and cerebral perfusion. So I haven't watched this whole movie. It really looks fantastic. I just downloaded it. So this is an abbreviated ED thoracotomy tray.
Specific thoracotomy tray, what would it include? Right. So this is an actual thoracotomy set we use for our traumas. You can see it's a panoply of instruments, and it is complex for folks not used to it. So let's build ourselves a ED specific thoracotomy tray and just separate out this huge assortment of clamps and such. So what do you need? Well, the first thing you need is a scalpel. Now, the first deficiency you'll see in this kit is they have a scalpel handle with no blade. And that's not going to work for an ED. It's very frustrating to have a patient you need to cut into the chest and try to actually insert a blade onto the handle. So you got two options. You could tape disposable scalpels to the outside of each of these kits, and that's okay, except I find people run out of scalpels and they steal them off the sides of the kit. And then when you actually need them, they're never there for you. So the way they handle it at shock trauma is they would put blades on two scalpels, big blades, and they would leave them in the little, peel away thing that the scalpels come in, and they would then sterilize those. So you'd have the already placed blade on the scalpel, two of them sitting in the kit. what we did at Elmhurst was we actually had discovered disposable scalpels that could be autoclaved. So you could put 2 disposable scalpels in your kit and then autoclave the tray and they'd be there for you. But this is not a good option, just having a handle. So the first thing you need is a scalpel with a blade already on, either taped to the outside or in the kit. And that's going to be what you're going to use to make your initial incision. Then you're going to want to cut through intercostals. And for that, you want a relatively heavy scissors. So you either want Mayos or even bandage scissors would be okay. My preference is these Mayos. These are nice. There's curved and straight bladed Mayos here because there's a curved blade. It's not sharp. So you can put one jaw into the chest and then cut up to the sternum and cut back down. And if you're going to clamshell, you just do the same thing on the other side. So you definitely want one big scissors. Now, what's next? So now you're actually through the intercostals. You have an incision there. If you're just going to do,
I was talking about the intercostal muscles.
the next thing you don't want is your finiscetto. Now, this is a situation that's not uncommon. Is this finiscetto is actually backwards. This is not supposed to be like this, because you'll see when we put these blades into the patient's chest, you can't actually open without the handles being up against the patient. You know, it's going to be sitting like this or like this. That's not how it's supposed to be. All right, so you definitely need a finiscetto though. Okay, now I recommend any inexperienced folks do clamshell thoracotomy because that's going to give you the biggest exposure and make it much easier than trying to look in the dark cave of a anterolateral thoracotomy. So what you're going to want is you're going to want this, which is called a Levski knife, which just latches under the sternum. And then you have this not that sharp blade, it doesn't need to be sharp, that touches sternum. And then there is a name for this hammer. I don't ever remember what it is, but this is what you hit your Levski knife with, and with 2 smacks, you're through sternum. So you definitely want one of those. Now, you could have a sterile trauma shears in there. Those will work as well. What you don't want, and some people have recommended, is the jiggly saw. I find that to be not that effective. Okay, now you're through sternum, you have a clamshell, you put your finiscetto in, now you're ready to do something. The first thing you want to do is actually relieve any possible pericardial tamponade, or if you have any gout, check if it's there. And so for that, you definitely want at least 1 pickups with teeth. And the teeth are important because when the pericardium gets tense, the non-toothed don't actually let you grab because the pericardium is so tense that you can't pick it up. So definitely you want 1, and because they inevitably fall on the floor, I think it's not a bad thing to have 2 pickups with teeth. Now, I would prefer, if I had my option, to have something this length with teeth. But I will certainly take either of these, and those are fine. So I'm going to have 2 of those because they're essential and they have a tendency to fall. All right, now you want to cut through pericardium. And for that, it would be nice to have some, let's see what we got in here. Yeah, here we go. So a nice long, more delicate set of scissors. These are your Mets and Bounds. These would be nice to have in there, though not essential. You can make your Mayos work if you have to, but that's a nice thing to have. All right. If you have not fixed the situation at this point, chances are the patient's not going to make it. And you could call that a complete set. But let's just go a little bit further. And let's say you had a big amount of bleeding coming from the lung, and you want to do something about that. Well, one of the nicest things to do is clamp the hilum. I don't like this hilar twisting. I think that's more theoretical than actually beneficial. The other thing you may want to do is cross-clamp the aorta. You're probably better off just compressing the aorta with your hand, but if you wanted to clamp, for both of those things, you probably want a vascular clamp. And the thing about a vascular clamp is they don't destroy tissue. So, and you can know it's a vascular clamp because if you could do this and it's not excruciatingly painful, then that's a vascular clamp.
Of course, then it's desterilized.
I recommend that you stock these side-biting Satinskys. And you know they're side-biting because here's a vascular clamp and it's straight. The side biters actually curve a little bit and have this angle. The nice thing about those is they're immediately discernible from a Kelly. And you know, if you have a long Kelly and you put this on a vessel, bad things are going to happen. You want a vascular clamp, and if you're not familiar with them, it's immediately obvious to you that this is not a standard Kelly. So having these really lets you know this is safe to put on a vessel. So if you wanted to clamp the aorta, this is nice. And I find this side biting Satinsky, you can do anything you need to do from the ED perspective. You can clamp the hilum, even though it's not the ideal, it's not a straight one, it'll work fine for that. You can clamp the aorta, and so I like having these, and I would actually stock 2 of these in preference to something like these straight ones, unless you really know that your people won't grab the wrong one. So you have multiple vascular clamps in here. I would grab the Satinsky for most of the things I would do. So I would put 2 of these Satinskys in there. Now, if you have done a clamshell and you have actually gotten the patient back and they get a blood pressure, they're going to start bleeding from their internal mammaries, and you just want to clamp those off. So you actually want 4 clamps, and they can be curved or straight. It doesn't really matter. I just have a preference for curved. So I would probably say in this kit, I'm going to put in 4 clamps. Maybe you put 2 straight and 2 curved or what have you. So I put 4 just standard clamps that you're used to from chest tubes. You might use this set to do a chest tube on the opposite side. So one of those could absolutely be used for your chest tube on the opposite side. So you're set on those. And then really the last thing I would say you need is a needle driver. Make sure it actually is corrugated, it's rough in there, not smooth. This is going to be you grabbing huge needles. And so that's the last component. So let's actually look at what the ED set would look like.
So you can see how large that is on your full
Laid it
chest
out,
thoracotomy
two
tray.
One inevitably falls or gets lost, or someone puts it in the sharps container. So 2 scalpels with their blades on, this doesn't have that, is the first step. And then you need some big set of scissors, like a Mayo. So that's your next step. And then you're going to consider opening the pericardium. So you want 1 or preferably probably 2 pickups with teeth. I'd like some longer ones. I'd take 1 short one, 1 long one. Be nice to have a Metz to actually cut that pericardium or any other tissue like the inferior pulmonary ligament you want to cut. If you wind up clamping the aorta, you're going to want probably 2 of these side biting Satinskys that'll clamp your hilum. It could clamp the aorta, it could clamp any vessel you want. If you're going to clamshell, we're going to have a Levski knife, hammer. For any of this, whether it's a anterolateral or clamshell thoracotomy, we're going to want our properly set up finishetto.
Whoops. Sorry. Uh-oh. Okay, I wanted to just say when we were right here, when he's showing you that finishetto,
Just some standard curve.
I want you to see what he was telling you. This is really important that because oftentimes it will come up, set up incorrectly. This circulating device that actually is what's going to promote the expansion of the finishetto, that has to be on the opposite side of the grabbers of the finishetto. So if you take it out and it looks like this, you've got to take this part off and turn it around so that the grabbing components of the finishetto, which are what are going to go down into the patient, are on the opposite side of your roller clamp. Now, why this is so important is because for most people, when you're going to open a chest, everyone is upset. Even the person who does it all the time, they're all going to be chaotic. They're going to be yelling. They're going to be upset. And it's really important to just have this standardized small tray. And the small tray can go on top of your thoracotomy cart, which has everything that a cardiothoracic surgeon is going to want. But the surgeon in an emergency situation, they're not going to have a scrub nurse. They need to just have what they need. Now, what I'm going to tell you about this, okay, that side clamp, right, which is going to allow me to clamp the aorta without causing vascular damage. Quite honestly, I prefer to have a resident. I've done it myself, but I'd much rather have a resident who reaches in and gently clamps the aorta. So if you don't have this, don't worry too much. Just make sure you've got somebody who's comfortable, who's sterile, reach in, clamp the aorta. You can clamp above and below the dissection, or you can use your clamp. Okay. All right. So I want to go back and just finish this up. I find this actually to be just fascinatingly good because he's really covering this component of what needs to be on your tray, which is
If the
1/3
patient manages
of
to
what's on
provide,
your chest.
we're gonna want just a
part.
standard curved and straight clamps. I'd probably put 4 of them in there. That would be a bonus, but you just want the regular 4 clamps, and 2 could be straight, 2 could be curved. And then if you're gonna sew anything up, whether it
A
be
needle driver.
closing the incision after the postmortem period, or actually sewing the heart, which I don't recommend you guys do. But anything you need to stitch with, maybe you're stitching your chest tube in the opposite side, you want a needle driver. And so this essentially, I think you can get everything you need to be done from an ED thoracotomy perspective for an ED tray. But I would really urge you to have the full thoracotomy set, because if the surgeon comes, they might want instruments that you don't need for your ED thoracotomy. So if you made an abbreviated tray and had a full thoracotomy tray, I think you'd be served well. That's it.
Fantastic. And that's exactly right. You need to have a setup that you can manage yourself. So this is an anterolateral thoracotomy. You can see here. And again, see where the grasper is inside the chest and the winding component is on the opposite side. So that was really important. I really don't think about that very much when I'm helping somebody with an opening the chest. But I work in an institution where my tools might actually be put together inappropriately. So again, you'll be able to pull that off, put it on the other side so that the grabbers are on the opposite side of the rotational tool that's actually going to open up the clamp to open up the chest. And that's what you're seeing here as well, that the chest is open. So here you are. Now you've got a nice, beautifully exposed heart and a beautifully exposed lung. That's going to allow you, if there's a cardiac arrest, to do direct paddles for cardioversion or for defibrillation. And remember, you're going to use 20 joules, 20 joules, 20 joules, never more, 20 joules, 20 joules, 20 joules in rapid succession when the chest is open and you're applying paddles onto the heart. Okay. Now, as he said, he doesn't recommend you guys, meaning he's talking about ED doctors. ED doctors are going to open the chest. They're going to drain the blood. They're going to see the bleeding. They might put on a clamp, but you need a CT surgeon to actually do any laceration repair work because they're so familiar with the cardiac structure, the electrical structure, the mechanical structure, and they'll be really cautious in repairing atrial or ventricular lacerations. So really, really important to remember, no one is saying that anyone but a CT surgeon should do laceration repairs. Here's a laceration that is adjacent to the coronary artery, and here it is right here, and the patient is bleeding. And this is just a basic repair of the coronary artery, getting it sutured back onto the ascending aorta. Here's a significant ventricular laceration, again, which also has to be surgically repaired, can be done at the bedside if that is the life-threatening issue that has occurred for your patient. And again, the only person who should do this is the cardiothoracic surgeon. Now, a trauma surgeon may do it, but really I would prefer to wait for the cardiothoracic surgeon. So really, really important for points to remember for you as a bedside nurse. And I left something really important off here. If there is suspicion or support that you have a patient with a penetrating ventricular atrial issue with a blunt cardiac trauma and aortic dissection, or with an aortic dissection from hypertension, you need to consider that you have to open the chest. If it's in the ascending aorta, you got to open the chest. And from opening to control should be about 3 minutes. It has to be fast. But in the meantime, because you're not the one who's opening the chest, you're getting the sterile equipment, you're getting the chest thoracotomy tray, you're getting the chest cart, the thoracotomy cart, and you need to know where that is and you need to know what's on it. And if you don't have an abbreviated tray, you need to build one. And the tray for opening the chest is relatively similar to the tray that's used to open a CTS chest, except that you're going to have, you can use METs, scissors for cutting the sutures, but it's going to be much easier. A lot of those steps that he was talking about are going to be much easier because the sternum has already been open. It's usually closed with wires. You got to do a wire cut as well. So you're opening the sutures, you're opening the wires, you're opening the sternum. You now have full access to the chest. If you're doing it in an emergency in the ED and a patient who is not a CTS patient, you got to open the chest. You're going to have to actually open the sutures and cut through the intercostal muscles. And that's what you're going to be using your scalpel with the big blade, and you're going to be using your mets or other really sharp scissors to open the intercostal muscles. You need to know the tray. You're not a surgical nurse. I don't think any of you, I mean, an OR nurse, you don't have to be. You need to be basically familiar with the tray so that you can assist whoever is opening the chest. But most importantly, you want to get that heart rate down. You want to decrease the blood pressure, and you want to proceed with caution with any agent that you're going to give the patient to reduce pain, because the likelihood is that it is also going to have vasodilation properties. So heart rate down before dropping pressure, heart rate down before treating for pain, unless you have an assured agent that does not cause vasodilation, of which I am mildly aware that the only agent I believe you could use in this scenario would be ketamine. And so that's a whole nother ball of wax. You got to be familiar with ketamine as well, because you don't want to be using fentanyl or morphine or Dilaudid. You'll have some hypotension associated with that, and that will exacerbate shear force injury that will further dissect your aorta. All right, my friends. Not saying you're prepared to open a chest, but I hope you have a better idea of what's going to happen in an emergency with an ascending aortic dissection or a cardiac tamponade in a patient who has not had their chest open previously, and what you're going to do for them and how you're going to treat them. I'm very grateful that you joined today on Wonderful Wednesday, Part 2, Cardiac Surgical Emergencies, Aortic Dissection. Open that chest. Thank you very much for coming. I appreciate you.